This program is brought to you by Emory University.
Thanks for letting me introduce Stephane. So for people that don't know, Stephane joined us about, I guess it's been 6+ months ago. Huge addition to our interventional program. He's a world-renowned CTO operator. I first got to know him back in 2009 when we both kind of got into the CTO arena. He's led the field in many of the areas. He authors one of the two sort of go-to textbooks in CTO PCI. Hosts probably the biggest European CTO course as the course director in Nice for ML-CTO. Outstanding operator, extremely well published, great speaker, and a great friend. And so it's a pleasure to introduce Stephane. I'm so happy to have him here, and I'm going to let him talk about why we open up CTOs at Emory. Thanks, Stephane.
Thanks, Bill, for this very nice introduction. Just want to make sure I'm not on mute. No, I'm not. It's a classic for me. So you can see, hope you see my slide, that this is last Friday where we were with one of our fellow and Pratik and Wissam, Bill and myself getting ready to do a live case, and all of this stemmed from a profound belief among all of us that this is the right thing to do for most of the patient. So these are my potential conflicts. I work pretty much with all the companies as a consultant, and no ties specific to any specific companies. So for those who may not have heard the fox and grapes story, I would like to tell it to you. It's one afternoon, the fox was walking through the forest and spotted a bunch of grapes hanging over a lofty branch. Just the thing to quench my thirst, he thought. Taking a few steps back, the fox jumped and just missed the hanging grapes. And again, the fox took a few paces back and tried to reach them, but still failed. Finally giving up, the fox turned up his nose and said, "They're probably sour anyway," and proceeded to walk away. So the moral of that story is that it's easy to despise what you cannot have. And that's been a long standing attitude towards CTOs among the community. This has profoundly changed over the last 15 years. This is Mr. Block. He's a 60-year-old type 2 diabetic. He's got angina, FRCP. We find collaterals from the LAD, and we find this is subtotal 99% stenosis. We all know what type of treatment will be, right? But if we find this, well, everybody will say, well, he's got collaterals, we can treat medically, blah, blah, and all of this. So I want to come back to that concept that patient selection is not anatomy selection. We want to get away from this paradigm, which is anatomy dictates whether a patient is candidate for PCI. It boils down to what one can do to actually change it. For coronary anatomy should rather dictate the PCI strategy than patient selection in the presence of ischemia and symptoms. And this is what we should do. Because in theory, at least in the 2013 ESC guidelines, just to let you know that the 2019 guidelines, there's only one mention of CTO and it's in a table. So at least, I don't know, I don't think that CTOs have gained a lot of popularity among Europeans, but at least at that time, they would say that the indication for a CTO should be the same as the subtotal stenosis, provided that there's viability, ischemia, and symptoms. This is a patient who has a normal LV. And you can see on the left that there's an LED missing. How can it be? It's because there are collateral channels coming from the right. It fills up the LED, as you can see, the LED on the right. Collateral channels are the spare wheel of the heart. Obviously, if I ask you to drive this Prius to more than 60 miles an hour, the car will not be stable. So, but it's okay to drive this Prius with the spare wheel at 30 miles an hour. It'll be okay. But this is what collaterals do. They don't allow your car to go to the speed you want, especially if the trunk is open, but that's another story. So why opening CTOs? Well, these are the reasons. To reduce ischemia and its consequence, we believe that this ischemia is harmful, to improve symptoms of angina or its equivalent, to improve tolerance to future events, to improve LV function. There's more data about it. To improve survival, I'll try to convince you that there's clearly good evidence that we can improve survival with CTOs. To improve outcomes in post-CABG patients and to achieve complete revascularization as an alternative to CABG. Let's start with ischemia. Collaterals, as I showed you, do not prevent ischemia. This is a seminal work done by Gerald Werner in the early 2000s, where he crossed the CTO, did not open the blockage, and put an FFR wire down and administered adenosine. And you can see that these are FFRs that are extremely low, from 0.2 to 0.6 in the majority of patients. This is another study that was done exactly with the same model. So they selected 50 patients with CTOs and 50 patients with severe lesions, but they were non-CTOs. So the severe lesions had no collaterals, the CTO lesions had collaterals. At baseline, the severe lesion had a pre-PCI FFR of 0.58, and it was lower in CTOs. And post-PCI, both improved to over 90. So there was more ischemia with CTOs versus the non-CTO lesion, despite collaterals. So it just shows you that collaterals do not prevent ischemia. Here's a case where I wanted to prove without any doubts that this is the case. 72-year-old male, 2-vessel disease without the LAD. He's got an OM and an RCA CTO. He's got severe inferior and inferior lateral wall ischemia. He's on good medical treatment. And this guy's referred to me to open the OM, but the RCA, because they're not sure if we should open the RCA because it's got such a big collateral. So here's the case, the long CTO of the RCA. And you will see if there's one collateral that someone should remember as the biggest collateral is ever seen is this one. This is a big epicardial collateral coming all around from the LAD going to the PD. And for this case, I wanted to show that this inferior ischemia is not coming from the OM CTO. It's coming from this PDA. So what we did, you can see there's an OM CTO as well, but that's not the inferior territorial, that's the lateral territorial. So I said, it must be the right. So what we did, we opened up the right. This is a dissection reentry, so re-entered with a Stingray. And once I re-entered with a Stingray, I delivered an FFR into the PDA, and I administered adenosine in the left guide, obviously, where the collaterals are going. This is the FFR we got, 0.73. Very low FFR with the biggest collateral you've ever seen. So, and we normalize the FFR, 0.94. And we open up the CTO of the OM. So again, another example that these patients are ischemic. And why ischemia matter? 2 new studies this year. One that I had the pleasure to comment in an editorial, this one, is from Paul Knappen and his group from Amsterdam. But they actually looked at the reduction in perfusion defects. So you've got the CTO here, it's open with very good result. This was the baseline defect in ischemia on a PET. And this is at 3 months, a reduction in well, absolutely no perfusion defect. And they looked at the relationship between the reduction in perfusion defects and outcomes. And up to 5 years follow-up, which is quite good, they could see that in the ones who had more than 3 segments of perfusion defects reduction, the delta, they had very good outcomes. But the one you could not reduce the ischemia to the same amount, it would amount to 38%, their outcome was not as good, with much higher rate of death in MI. If you look at the other way that they analyze the data is that when you would still get, if you would get 0 segment of ischemia, no residual ischemia at 3 months, these people are doing very well. But if you have more than one or more ischemia, a segment of ischemia, which is half of the patient, they still have a residual outcome that is not as good as the one don't have ischemia. So in a comment that we wrote, Dr. Sandesera and myself, we said, it may be the time to put aside certain dogmas and consider optimizing stent and distal disease when possible. We used to say that, distal disease is remodeling, but I think you need to use IVUS and make sure that what's present into the distal bed is actually negative remodeling and not true atherosclerosis that needs to be improved. We need also to do a better job at protecting side branches, optimizing final flow. And also, while we say that cutting off meds might be a good outcome following CTO PCI, maybe an open artery with optimal medical therapy leads to best outcomes, but that would be to be tested in a study. This is probably the best study I've ever seen in the CTO world this year. And actually was brought to the Euro CTO this year as one of the best from CCI. Peter Kayert and his colleague from Belgium, what they did is that they use IFR, but this time they delivered IFR through, so not new like they would use to do with FFR, so delivered through the microcatheter, and they measured the IFR distal. And then they did it after the CTO PCI. This is the novel part of this thing. When they had a normal IFR, they were happy, good. And when they had an abnormal residual IFR, they would do a pullback. And when the pullback would suggest that there was focal, then they would optimize the treatment and look at outcomes. So this is the good news. As you can see with IFR, most of the CTOs had like super profoundly low IFR, like 0.33. You never see this in open arteries. So 0.33. And they would normalize to 0.93 on average with all patients. But this is this group here where they don't normalize, where they looked a bit more in detail of what was happening with these patients. And what they did is that in 12 patients, where the median IFR at the end of the procedure is 0.84, they were able to bring it to 0.90. And what did they do? Well, they found focal, and they put additional stents, and they optimized their result. So I think there's something to learn from this, and I think we have to be doing a better job, and it's maybe bringing the patient back for testing at 3 months and look for residual ischemia, and then maybe bring the patient back to the cath lab and optimize the result, because it seems to have an impact on their heart outcomes. To improve symptoms of angina or its equivalent, it is exactly why we're doing this procedure. This is the most recent meta-analysis looking at successful CTO PCI versus failure. And you can see that there's absolutely no doubt that it favors success versus a failure to open the artery. There's a big Italian registry with 302 patients and looking at successful versus failed attempt, and then they look at a 1-year follow-up. The vast majority are now asymptomatic versus in the failed, they will more be in the 2 and class 3 and 4. Open CTO was aimed at looking at improvement on the short term of quality of life. Most patients who underwent CTO PCI in the open CTO large American study were having symptoms because of angina. And as you can see, opening the artery was associated with improvement of several domains of the Sierra questionnaire scores, and also improvement in depression score. This is a study we did in Quebec, focusing on patients with angina. And actually, you could see that at baseline, these patients were very, very handicapped by their ischemia and their CTO. 73% had already had a PCI, 33 were post-cabbage, and they were in CCS class 3 and 4, and 60%. GCTO 2.3 and the success rate of 95%. And you can see we could actually normalize their experience. And the message of this paper is that it had no relationship with the complexity. We could get as much improvement in these domains with complex CTOs, with dissection reentry, with post-cabbage or no cabbage. So therefore, you should not select the easy because you think that they're going to benefit the most. No, the very tough one benefit as much as the easy. The only thing that would make a difference on the long term in improvement was if you were able to open or not the CTO. And not surprisingly, these patients with the failure were not as satisfied and had much more angina. So the Euro CTO trial tested in a randomized fashion, however, not blinded, the optimal CTO PCI on top of optimal medical therapy versus only optimal medical treatment. And you can see that CTO PCI was associated with improvement in physical limitation, angina frequency and quality of life, and reduction in angina frequency. So this is quite fair and accepted in the community that CTO PCI works, reduces ischemia, improves outcomes, and is probably better than just optimal medical therapy for these patients. Does CTO PCI improve tolerance to future events? We believe it does, but it's going to be very difficult to prove into a randomized trial. The concept of double jeopardy of coronary interdependence is the following. You know, Mother Nature gave us 3 vessels, not because one is supposed to do the job of the other. It's like, but you know, in our world, it's like you would ask orthopedic surgeons to prove that someone who has 2 legs can run faster than someone who has 1 leg. But you know, in cardiology, everything has to come from multi-center randomized trial with a lot of things. But when you look at the plausibility of that, if there's one thing that happens to this artery that gives the collateral to the other one, things will not go well. And this is what we know from many, many studies that have shown that if you have a STEMI and you present and you have already a CTO, so therefore you block another artery on top of your CTO, but your mortality is not around 5 to 10% like everybody else's mortality with a STEMI. It's more around 30 to 40%. So it raises your risk of mortality if you already have a CTO. So you'd like to think that get rid of that CTO so I can survive through my future STEMI, right? But being able to prove that in a randomized trial is extremely difficult. However, if you look at observational data, when you have a CTO, your risk of mortality at 30 days is very high. You get like to 25 to 30%. But the residual, if you do a landmark analysis, seems like the CTOs are still, you know, making like people more at risk of mortality on the long term. So that was the baseline of the EXPLORE trial, which is a randomized study that compared, that was trying to look at the impact of opening a CTO in a patient who just had a STEMI. And of course, to make a small sample size, they decided that their primary outcome would be left ventricular ejection at 4 months. I didn't find any difference. The left ejection fraction of 4 months by opening the CTO, that's the satellite vessel, didn't improve the LV function. However, does it have anything to do with what I just said to you about tolerance to future events? Of course not. It's 4 months. It's a small sample. There was no evaluation of ischemia, and I really doubt about the hypothesis. Why the hell would you think that there would be a difference in EF at 4 months when opening a CTO? So it depends on everything boils down to your hypothesis. Like if your hypothesis doesn't make sense, well, your answer won't make sense. And it's exactly what I take from that study. So to improve LV function, we have plenty of studies that have shown that once you're dealing with viable tissue and you do either cabbage or revascularization with PCI or CTO PCI, we can improve LV function. So my good friend and co-director of the MLCTO, Kambis Mashayeki, did a beautiful study. And his hypothesis was like, I'm just going to look at the segment where the ischemia is on an MRI and look at regional function on an MRI when you open the CTO or not. And it didn't find any difference in contraction or thickening of the wall where the CTO was open or the CTO was not open. However, like any other study, they showed that the MACE rate was lower with CTO PCI than non-CTO PCI. So their take of the study was that for the majority of patients with CTO lesion, recovery of the impaired wall motion of the CTO territory with PCI of relevant coexistent non-CTO is similar. So therefore, it's all a question of burden of ischemia. If you're able to open other vessels and provide clarals to that area, you'll be able to improve as much the segmental function. What they showed, however, very interestingly, is that if there was only one CTO, when you would open the CTO, well, you would have the same benefit. So in single vessel patient who have a CTO. And so their take is that with more extensive CAD, maybe the effect is blurred by the overall effect of improved flow due to PCI of other lesions. And nevertheless, again, CTO PCI seems to improve major adverse events on the long term. Improve survival. Well, it's funny because why should we be aiming at improving survival when doing CTO PCI when we know that non-CTO PCI does not improve survival either? But it's like you would go to your hip surgeon and say, you know, what you're doing is not very useful because you don't improve survival. Well, of course you don't improve survival, but you make people walk. So, but nevertheless, even if this could be the case, when you look at all the meta-analysis comparing successful versus non-successful CTO PCI, there's a consistent 48% reduction in mortality with success. So CTO PCI may be the only subset of angioplasty or PCI aside STEMIs that improve survival. And it is not because you're a failed make him die. It's not the point. It's not it's the non-revascularized CTO or the failed CTO that make all that burden of mortality. So others have tried to say we're going to find that treating CTO PCI improves art outcomes. The decision CTO was a study from South Korea, where they actually randomized patients to optimal medical therapy versus CTO PCI. Although there was about a 20% crossover, they said that Dr. John was very quick to say that the first clinical trial fails to deliver. But when you look a bit more at the population, very different to what we're dealing with. 1% of post-CABG, whereas probably in Emory, 50% of CTO PCI are post-CABG. So really, really profoundly different. A lot of patients were multi-vessel disease, and DAC score was intermediate. And they didn't find any difference in terms of death, MI, stroke, or any repeat revascularization. But I'm still trying to find a study where stroke or MI could be reduced by CTO PCI. So therefore, when you're putting a lot of noise into your primary endpoint, you bias towards the null hypothesis. And when I look carefully at that study, when you look at death from any cause, PCI, the death was 1.9%, which is 3.6% in cardiac death. And this is exactly a 1.7 absolute reduction, which is a 47 relative risk reduction in mortality, exactly what has been observed in the studies. So is that a beta error? Of course, it's underpowered, but it doesn't say that the effect might not be true. So in the CTO arc that I had the honor to chair with Greg Stone, and we published this year in Circulation. I'm the corresponding author on this paper. Basically, we said it depends on the criteria of your future trial will depend on what you want to prove. So if you want to prove something on quality of life, you should select patients who have reduced quality of life. Of course, if you take patients who feel very, very good, it's going to be very difficult to make them feel better. So you have to take patients who are feeling not so good. The survival, if you have survival or MACE as an endpoint, the patient with any symptom could be taken. Functional, you have that takes someone who has reduced exercise. And in terms of follow-up on its quality of life and functional outcomes, I think 3 months is good, but MACE and effect durability should be 1 year. To improve outcomes at post-CABG, for sure. When you're dealing with post-CABG, as we do in Emory, 50% of patients who've had a prior CABG have a CTO in their coronaries. And why is that? It's because CABG causes CTOs. Because if this is a study where they look at the fate of the native coronary arteries, and this is like the prevalence of preoperative CTOs. So in the LADs, prior to going to the OR, 20% in the LAD, 20% in the CIRC, and about 40% in the RCA had a CTO. And 1 year later, and don't tell me it's a spontaneous event, it doesn't make sense. They add about 20% more CTOs in each of these arteries. What is a predictor of it? Is which if you have a very severe stenosis, and also if you put a vein graft. So here's the evolution of a native coronary artery disease. And then this is not, the whole concept of you're putting a graft, so therefore you protect the artery for spontaneous rupture, and that's the reason why CABG is superior to PCI, is to me a big fallacy. So here's the evolution of native coronary disease with a CABG. You go through a lesion, there's a reduction in flow. So therefore, you put the CABG, and then what's happening? There's going to be competitive flow at the level of the lesion, which leads to occlusion because you've got competitive flow. And as long as this graft is functioning, that's fine. But when the graft becomes disease, then at some point, the graft will occlude, and then the native artery will be filled with collateral channels. And in these cases, we sometimes use the occluded SVG to open the CTO, and then we restore the flow. So it's sort of thinking that should we go through this whole cycle of SVG if the ultimate goal is to put a stent. When you look at the intermediate lesions, 30 to 60% in the VELITY 1 and VELITY 2 trial that were done in Quebec City. This is the spontaneous events in medical therapy in SVGs. At 5 years, 55% will have an event, and there's nothing to predict which lesion will be bursting. It's only cholesterol value that predicts which lesion will be bursting. So this is very a ticking bomb in your heart. Doing DES or BMS in SVG, well, the big DIVA trial, the latest study from Manos Bilakis, published in the Lancet in 2018, over close to 600 patients randomized to DS or BMS. Absolutely no difference if you put a DS or a BMS in an SVG. And I would like to bring to your attention that at 1 year, there's 20% of these SVG that have had a failure, which is either a restenosis or an occlusion. So therefore, it's not benign to deal with it with an SVG. And we also know that treating a native leads to better outcome in terms of death MI revascularization than treating the SVG in the post-CABG population. So here's an example here. What do you do if you don't have CTO-PCI skills? You're going to treat this 37-year-old sequential graft and put a filter. Well, you don't know how long it's going to take, but you may expect that this will close sometimes. So very severe proximal stenosis on the SVG. And what we ended up doing, we tried to go integrate, we could not, we went retrograde. We opened up the native, and all of a sudden we had to deal with the second CTO in the mid-LED. And this is the final result where we reconstructed the native LED diagonal and coil the graft so that the graft is not giving any competitive flow. And at the end, you can see now that we are bringing the patient 6 months later with very nice healing of the native left system. And we were able to open up the right coronary this time with a very good result. And the patient has been doing extremely well now with native coronary treatment. To achieve complete revascularization as an alternative to CABG is certainly something that we want to achieve if you want to do good revascularization and help the patient. This is the fate of CTOs in the early 2000. in the Canadian registry. And of course, I was not into that group because the PCI would have been higher. So, but 44 were medically managed and 26% were sent to bypass. And very interestingly, 11% of CTOs were not grafted, despite the fact that they're sent to CABG. The CTO itself is not grafted. This is another analysis from the syntax trial. What they look at the subgroup of patients who had total occlusion. So you've got about 500 patients who had a total occlusion, and you compare what they did when they were randomized to either PCI or CABG. When they went to PCI, the percentage of successful opening of that occlusion, and they were not CTOs, they were total occlusion, was only 49%. And most of the reason why they were not able to open is because they were total occlusions, they were unable to dilate. So basically, they were not doing a good job with the occlusion in syntax. Let's look at the CABG now. Well, 32% of all the CTOs were not grafted. And this is something that we've seen in practice. You send your patient for CABG, he comes back and the CTO itself is not grafted. But of course, it's because CABG doesn't work by intention to treat. You got to find a vessel. And sometimes the surgeon will say that it was a diseased vessel, it was an inadequate conduit, I couldn't find a vessel, and blah, blah. In the end, from this analysis is that an incomplete revascularization, either with PCI or CABG, was associated with much worse outcome than a complete revascularization. When you graft a CTO in the FRCP trial, FRCP 4 trial was off pump versus on pump, but they looked at a sub-analysis, very interesting. They look at the fate of their graft at 1 year. And when they would put Lima on the LED, the patency was excellent. But when they would put an SVG on a CIRC, on an RCA, the patency was only 22%. So I told you that when you have a CTO, the patient is sent for CABG. In 1/3 of the patient, at least in one study, we know the vessel was not grafted. And if they grafted, 4 out of 5 grafts were occluded. So it's not easy to treat CTO surgically. And why is that? It's because you've got a huge effect of remodeling. So when you open a CTO, we all know it, over time, over 6 months, there's going to be positive remodeling. So the surgeon doesn't have this advantage when he faces the vessel. This is an example of where an IMA would have failed. This is an LED CTO. You can see that it's occluded, and the vessel is very tiny distant. So my colleague Nicolas Boudou from France opened up the vessel, and what they do sometimes in France, they bring the patient back for a control angiogram. They look at the angiogram and say, well, I don't know what I did, but hopefully it's going to be good. And this is 4 months later with huge positive remodeling. So of course, this IMA on the LED would not have survived because this vessel was not ready. And by opening the CTO, we made that vessel better and probably graftable again in the future. So in the Syntax 2 trial, it's at the tier outcome was presented TCT 2008. They did FFR and IFR, used 3rd generation DS, IVUS guided stent optimization, and contemporary CTO. And this is very different to FAME3, where FAME3, they didn't use IVUS to optimize their outcomes, but it's beyond the discussion right now. What they found is at least when you're using optimized CTO techniques, when you open the CTOs, when you optimize your outcomes with IVUS, you reach much better outcomes compared to earlier PCI outcomes, and they match CABG outcomes. So in summary, what are the potential benefits to patients? Symptom relief and improved quality of life is what patient wants. I'm still looking for that patient who will be coming to tell me, can you make me live longer with my symptoms? It's not what they want. They want to be feeling better, and it's already quite well demonstrated in EuroCTO trial showed it. Improved tolerance to future events, possible. The EXPLORE trial failed to test an appropriate sample, and again, it's going to be very difficult because the real endpoint is mortality. Reduce MI rate, there's no evidence that CTO PCI reduces MI. So therefore, MI is useless in combined endpoints, and you should probably, if you really want to show something, is to show mortality. Is it useful CTO PCI to treat a native instead of an SVG? Of course, and it makes sense. We don't have randomized data, but a lot of the observational data support opening the native instead of the graft, because we know that saphenous graft PCI does not yield good outcomes. Improved survival, we will never have stronger evidence, but I still think that CTO might be the only PCI indication besides STEMI where survival is improved. And if you look at the mortality rates in decision CTO was 3.6 versus 1.9. You would need 1,400 patients per group, so a 3,000 trial. If you go with a more modest hypothesis, 3.6% mortality with a 30% relative risk reduction, you need an 8,000 patient trial. This is not realistic. With 800 patients only in decision CTO, it took 6 years to recruit. So 8,000 is totally impossible. And therefore, I think we will have to live with the absence of evidence from randomized trial. And of course, as an alternative to CABG for multivessel PCI, if complete revascularization is achievable, you need to master CTO PCI. There's a relationship between indication, expertise, and risk. Obviously, if the indication is softer, the attempt rate should be lower. Obviously, with stronger, you should get more attempt. But obviously, if you get better expertise, like we have here in Emory, we sometimes will be playing in the realm of softer indication because we know we can do these procedures with lower risk. And obviously, if the risk goes high, your attempt rate will be lower. And I want to bring your attention to this before finishing, is that any operator facing CTOs and a patient with ischemia and or angina will be defined as a 2x2 attitude. These operators either attempt to open the CTO or don't attempt to open. And they ultimately refer to CTO PCI expert, or sometimes they don't refer or do not mention the option that CTO PCI is feasible. I want to dissect, this is based on 10 years of experience, and I'll tell you what happens in each of the boxes. The one who attempts to open and refers as failure, it's good. He builds his experience, it's good for the patient, it's good for himself because he gets experience, and then the program gets better. The ones who do not attempt to open and refer for CTO PCI, it's all good too. Nobody can be an expert in everything. All of our colleagues from the structural program, they usually don't do CTOs, but they refer their cases when they have good indication, and that's perfectly fine with me, and we encourage them. Where we start to have a bit of problems is the guy who tries to open the CTO, fails to open the CTO, it don't refer the patient, and don't mention the option that this could be done. It's bad in court. So why did you try to open the CTO if your objective was not ultimately to open it anyway by yourself or someone else? But at least the positive side of it is that it sends a message to the referring doc that this can be done, and then sometimes the patient will come back to the expert and we will have the chance to open this RV. Where I have a big problem is the ones who do not attempt to open, they do not refer, they do not mention the option that this can be done. This is really bad and cause prejudice to the patient. It sends a message that it does not need or cannot be done. It's unrevascularizable, and then these patients live with their problem, whereas the option should have been open at least for the patient. And I've seen patients come in 4 times for an angiogram with a normal LED where the IFR was done, always normal in the LED, and the RCA was a CTO. So this is not what we should do. So how to open CTOs, and this is beyond what I'm going to be talking today. You remember that story with my FACC? Well, the FACC just needed a ladder, and with the ladder, it would have been able to get to the grapes. So you need the tools, you need the techniques, you need the perseverance, you need a bit of boldness, but with the boldness, you need to have self-critique, because otherwise you become a cowboy, and that's not good. And how you become a good CT operator, you want to learn more, you want to go to meetings, you want to read on what people have written. We have our book now coming, the 2nd edition. with Springer. Manos Mirakis has also a beautiful book with a step-by-step approach. This CTO summit this year, all cases were done by Emory, by my two friends, Wissam and Bill. And stay tuned for the next edition of Complex and CTO Summit. That's going to be from CRF, where Bill now is one of the co-director, and congratulations, Bill, for achieving that status. This is we should all be proud in Emory to have you on board with CRF for that very important course that has over 20 years of experience. This is my ML CTO. We're heading to the 7th edition. We've achieved to be the biggest course in Europe. We gather up to 32 countries. Alexandre Avran, Candice Machaiki, co-director with me. And we're looking forward to our 7th edition with, again, which is new this year and will be ongoing, an Emory hub and the US hub where I can invite all the Americans that can travel to Europe to comment on the cases. In conclusion, opening CTOs reduce angina and ischemia as collaterals cannot provide enough flow during stress. As you saw, I showed you extremely low FFR and extremely low IFR. And new data suggests that optimizing outflow may further improve prognosis. And I think it's on the radar of how good we do our job is to be able to optimize and secure our open artery with probably better outflow assessment. CTO PCI improves quality of life. We have no doubt about it. Although CTOs don't cause MI, the presence of a CTO decreases tolerance to future events in non-CTO vessel. And this is going to be very difficult to check in a future study because you would need to treat a truckload of CTOs to show ultimately a reduction in mortality. CTO PCI is a necessary alternative to SVT PCR, redo CABG, and post-CABG patients with degenerated SVGs. There's no trial that can be done in that area. We get these patients being referred to us on a daily basis, and that's where the limitation of CABG happens. Like up to 10 years, CABG does well, but beyond, well, they come back in the realm of PCI and complex PCI. CTO may be the only non-STEMI lesion subset where PCI improves survival, although our CT quality data will always be lacking in my mind. And the lack of randomized data doesn't mean that there's a lack of evidence and biological plausibility. The observational study is strong in favor of survival, although it may be partially biased, we cannot completely dismiss that data. And CTO PCI needs to be mastered to provide complete revascularization as an alternative to CABG. So thank you very much for your attention, and I look forward to answer to your questions.
Stephane, it's a great talk, really. Thanks so much. I'm gonna let the audience ask some questions. I just wanted to ask one question I think comes up pretty routinely and sort of get your take on it. But, you know, when we talk about CTO PCI, the reason why I think people have been a little bit hesitant about referring for CTO PCI or preferring to go to CABG is the inherent or the thought of success rates are going to be lower and complication rates are going to be higher. And talk a little bit about those kind of numbers as compared to standard PCI and what your success rates should be with the experienced CTO program.
It's a great question. I think it's obviously something that is in the mind of people referring to these procedures. The risk of a CTO PCI is higher than a non-CTO PCI. We're talking about a risk of mortality that's probably around 1%, and it's probably around 1.5 to 2% when you're dealing with a post-CABG patient. However, it depends to what you compare to. If you compare to an SVG PCI in ACC and CDR, the mortality following an SVG PCI is 1.5%. The same as with the CTO PCI. And of course, this is the risk. The risk of perforation is about 5 to 10%, but the ones leading to tamponade or leading to treatment is less than 1%. So when we quote the patient in the post-CABG, I always say 2 to 3% risk of MACE, and the non-CABG, I would say 1 or 2% risk of MACE, with stroke being less than 1%. Tamponade being less than 1%. And I try to individualize compared to what I see and try to be as precise as possible with what I see. If I'm dealing with a post-CABG super long CTO and I need to go through an epicardial to do it, of course I will be quoting more a higher risk of mortality. But it's amazing how people cannot deal with low risk numbers. You know, human beings are not meant to be able to understand what a 2% risk is compared to 1% risk. Well, it's a 50% increase in the risk. It's a double the risk, right? But 1 and 2 is equal to them in their mind. And that's the reason why you have to be also very honest and talk to them about what you think they will go through and what's going to happen. And that's one thing. And also the success rate will depend on what you're dealing with. Overall, 90% success rate. And depending on the type of lesions, we're probably in the 85 to 90% success rate in Emory because we get those post-CABG and they're more difficult. However, if you talk about the simpler CTOs with tapered cap and non-CABG patient, and this is a big difference. When you compare the non-CABG and CABG cases, the non-CABG patients have over 90% success. And this is what you see in Europe and in Japan, where they are dealing with only less than 10% of their patient being post-CABG with super high success rate. It's got to be very different for a post-CABG patient. You get more into the 85 to 90% because sometimes you deal with issues that are absolutely unique to post-CABG. But nevertheless, in our paper we published, we were in the 90s. And a lot of people in the US have published their data in post-CABG. They're in the 90s in terms of success in the same realm of complications. So I think we can say that this procedure is mature. It is, people understand what are the risks of it, where we can get better. We've learned a lot as a community from sharing a lot of our complications and not hiding them, but actually trying to make each other better at understanding, identifying them, and treating them early.
So what juxtapose that you're a 90% operator, if you look at NCDR and other things, like what's the national average on success rates on CTOs is only in the mid 50s, I would guess, and probably has a big reason.
I think in the last data from Manos Brilakis, when he looked at the CTO PCI success, was around 60%. And he looked at the top, there was only, I think, 20 operators doing more than 50 a year. And these had a success rate over 80. So actually the volume triggers success. This has been shown in previous studies, not only in CTO PCI and everything. The more you do, you get better. Although there's a lot of, lobby to sort of justify that you can still be a low volume operator and still have good outcomes if you clean your denominator. Well, if you don't clean your denominator, if you take everything that needs to be done and you don't look at the angiogram, but you really want to open the artery for the patient, you cannot be good if you don't do a certain amount of these cases, and you have to be dedicated. So I would say that, yeah, the success rate overall is low. It probably includes a lot of the dabbling, boom, 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 done, and I fail. But in the ones who are really committed and the ones who have adopted the hybrid approach and can master the retrograde approach and dissection reentry, you get more operators that are into the 80 and 90% success, I would say.
Let me ask you, Pooja put through the chat, you talked a little bit about the EXPLORE trial, and she's asking for patients with depressed ejection fractions. When you fix the CTO, do you see improvement of ejection fractions? And I know with EXPLORE, everybody had EFs in the mid 40s or low mid 40s to start with, so it's hard to show a difference. But when you got into the LAD group, where EFs were lower, you saw an improvement that was statistically significant. Talk a little bit about CTO PCI and low EF patients. Does it improve if there's very low EFs, and how about the safety of the procedure in those patients?
That's a very good question. I didn't specifically talk about the low EF group, but there's a very nice study from the Euro CTO group where they actually looked at the patient with low EF and followed up afterward first, it demonstrated that CTO-PCI in low EF patient is a safe procedure, but it's on average, their EF was around 25%. And then they also demonstrated an improvement in EF as an observational data. So there's no comparator group. What we can say is that CTO-PCI in low EF increases the risk of CTO-PCI without any doubts. And this is where the whole community has developed the CHIP, or the complex higher risk but indicated patient subgroup, where we have incorporated this very higher risk patient into our patient beyond just the CTO patient, because lots of these patients have other type of disease. They have multivessel disease, there's surgical turn down, they have left main disease, they have complex, they have, and it's not only the CTO. Usually when you're dealing with someone who has a low EF, you're dealing with someone who has had prior CABG and is depending on only one vessel, providing lots of collaterals to all the vessels and everything. And that's where we are all learning as a community, where these devices, supporting devices such as Impella and everything, can help us go through the procedure or arm the patient. And that's very important that we are into the Protect 4 trial, where we really want to randomize these patients to ultimately demonstrate that protected PCI in higher risk patient can be protective. But again, I think to finally summarize, LV disc function can be improved with revascularization. Has been shown in Stitch, and it's still shown with any form of revascularization, but it will also be improved with medical therapy if the territory is viable. So there's a big confounding factor where usually you're doing the revascularization, but you improve medical therapy. And that is also one confounding factor, that you cannot attribute all of the benefits from the revascularization. And it's been shown in Stitch as well. So I'm careful to say that the CTO-PCI in itself is the reason why these patients will improve their ejection fraction. It's always a combination of a lot of things, but one thing to say is that the lower their EF, the higher their risk of complication, especially if you're thinking of using the non-diseased RV as a donor for a retrograde approach. This is probably where you and I and our group lean towards support more than not. But if you can turn these procedure into an integrated procedure without having to instrument any other artery, then these procedures can be done quite safely without support.
Talk a little bit about exercise stress testing before and after. Do you do them routinely to objectively show that you've made a change in the patient's symptoms? Do you just go clinically, or should we be following that more objectively?
That's a good question. It's a practical issue sometimes, right? Because they've already had a functional test, they've already had an angiogram. They're mostly referred by other providers, and you would have to have a program that incorporates that as part of the program. And none of the programs that I've been either in Quebec City or McGill, we had that incorporated into our program. And of course, we would derive a lot of excellent research data out of it, just to demonstrate an increase in or a time to ischemia reduction would be a huge achievement and a very simple study to do. Although, in practice, it's very difficult to implement. Never mind the payers here in the US, where they've already had any other tests. So this is something that would be elegant to do, but would probably have to be incorporated into more programmatic and research environment.
Let me ask you too now. So with Syntax 2 showing that maybe diabetes isn't a variable for durability with PCI versus CABG, and some other studies that are starting to support that. And now that you can do 90% of all CTOs and obviously 100% of non-CTOs, which is something I think gets lost in this discussion, is that the non-CTO PCI is pretty simple nowadays. And so who are you sending to Cabbage?
Well, if I'm up to date and I look at the data and I read, when you look at the syntax at the FAME3 data, we could not demonstrate, the equivalence to Cabbage or non-inferiority to Cabbage with PCI, with the ischemia-guided PCI. However, I'm always concerned with these trials like this. It's only 1 year follow-up. Cabbage is doing better at 1 year than PCI. But we all know what's happening with post-Cabbage patient when they hit the 7, 8 years and 9 years. And 1 year is teenage for Cabbage, and 5 years is it's infancy. And 5 years is teenage. Really, what we see with Cabbage is when the SVGs tend to be diseased, you get a whole group of patients who are coming back to you. It's probably the only thing that we implant in patients that have longevity sometimes shorter than the lifespan of the patient. Think about it. Like, no one would put a hip prosthesis that would not have a longevity that's longer than the patient. Here, sometimes I see patients going for surgery and they receive an SVG, and that half of them will be occluded in 10 years. Now, of course, if you're 60 years old, your life expectancy is not 70, it should be more 80. So fundamentally, I have a problem with that. And lots of surgeons have problems with that, but it doesn't seem that all surgeons have problems with that. So this variability that probably triggers more hybrid revascularization. I'm used to LED treatment of non-LED disease with more PCI, and I think the solution is into a more hybrid solution, more arterial grafts, and more optimized PCI of non-LED vessels, and that's probably the future if you want to avoid the post-Cabbage disaster like we get sometimes with a Lima patent on the LED, all grafts occluded, and everything's a CTO, and the patient is back to class 3 or 4 angina. So I think there's still going to be a pressure and everything to refer to Cabbage, because there's ample data to suggest on the short term that Cabbage does better. Even in Excel in the left main, you still have a signal of superiority with Cabbage. However, it took 10 years for Stitch to demonstrate that revascularization in heart failure patient was beneficial and over medical therapy. And I wouldn't be surprised that the longer we will follow the patient, the better PCI will do, because it's expected that SVG will be starting to fail and PCI will have a more stable long-term outcomes. But this is only my editorial thinking on the subject.
The preceding program is copyrighted by Emory University.